of our Facebook Live Kidney Talk. Sorry, I have to, all these things pop up all of a sudden. I apologize for that. I can't believe it's December already. I don't know if you're with me, but this year has just flown by. Before we started our presentation, I wanted just to kind of wrap up the year and just to tell you all that we've done here at the New Mexico Kidney Foundation. Starting in February, we had a really successful conference with the Southwest Nephrology Symposium, and that's nurse practitioners hold that, and it was amazing. They had over 100 participants for that, and that was in February. And then we held successful classes at the Rio Rancho Elementary School. And I tell you, those kids are smart as whips. They had so many questions for us, and they got to look under the microscope at cells for the kidneys, and they just had such a pleasant time. We also have had 25 scholarships, dental scholarships, and 2 successful kidney transplants because of those scholarships. And then along with that, I just want to do a personal thank you. We've had, last night, how could I almost forget? Last night we had our first telepathology seminar. We had 39 doctors, nurses, and nurse practitioners, and physician assistants attend, and we went over 10 cases. It was awesome. It was such a learning experience for everyone that attended. We also had 2 very successful fundraisers. In March, we had a pickleball fundraiser, and then on Giving Tuesday, which was in November, we held a fundraiser at Cello's where we had such a outpour of support. And I really just want to thank you. I want to thank the viewers for this year and watching the kidney talks and participating. And above all, I want to thank everyone for your donations. None of this could have been done. The education that we do, the scholarships that we give out, nothing could be done without you and your support. And I just want to thank you from the bottom of our heart. With that being said, now we'll go on to our wonderful speaker. I know you guys are just going to love her. Stephanie, she is a renal nurse. She currently works at Renal Medical Associates. And I had the pleasure of speaking with her prior to this engagement, and she has abundant experience in renal medicine. So I am really anxious to hear from her, and she's going to talk to us about chronic kidney disease. And we know that this is a topic on a lot of people's minds, and even if it's not, it's something that affects us in some one way or another. So with no further ado, I'm going to turn it over to Miss Stephanie. How are you doing?
Good evening, everybody. I'm excited to do this talk. This is what I take care of kidney patients all day and every day at work. And I wanted to put awareness out on chronic kidney disease because it affects so many people. And, you know, the CDC reports like 37 million Americans have CKD, and 90% of them don't even know they have it. So early diagnosis, treatment directly affect outcomes. And so I'm just going to start off my talk with just kind of giving you some information about our kidneys, and then I'll go into chronic kidney disease, what it is, how it's diagnosed, and some of the complications that come along with the disease. So typically, each of us are born with 2 kidneys, and they're located in the back on each side of the spine, tucked underneath the rib cage. So the kidneys are protected by the rib cage. Each kidney is about 12 to 13 centimeters long. So it's kind of like, I don't know if you can see this, but looks like this. And so we have 2 of these. And our kidneys do a lot of important things. So one of the main things it does is it filters out our body's blood. It does a big job. It's filtering about half a cup per minute, removing waste products. And it actually, there's about 180 liters of fluid that go through each kidney. So usually it's about maybe 2 liters of urine that's made. And so the filtering, it's made up a lot of a lot of water and electrolytes. So our kidneys, I always think of it as like a washing machine, like a coffee filter. It That's the primary function, but it does a lot of things. It helps control blood pressure. It helps make red blood cells. It helps balance out our electrolytes. So, and normally, as we all age, we all lose kidney function. So say a person that's 20 to 29 years of age, their kidney function will be like 116%. So, and we estimate the kidney function based on a calculation called estimated glomerular filtration. So in layman's terms, that's like the percentage of kidney function. So normally a healthy young person without any chronic disease, kidneys function at 100%, 120% or so. But like I said, as we all age, we all start losing some type of a little bit of kidney function. So that's what a healthy kidney does. It has 1 million filters on each kidney, usually like 1 million, and they're called nephrons. And these nephrons are made up of tiny little blood vessels. They look like it looks like the nephrons look like a tiny ball, and that's where the filtration takes place. So, so with chronic kidney disease, it's known. It's a condition that's characterized by gradual loss of kidney function over time. There's no cure for chronic kidney disease, but if it's diagnosed early, we can treat it to slow the progression of kidney disease. And there's certain common complications that I'll talk about that come along with kidney disease. And once you have chronic kidney disease, your kidneys don't improve. So our goal is to just maintain it and prevent it from getting worse. So our kidneys also affect all the other systems in the body, like the heart, which is closely related. And so, and chronic kidney disease, it's considered to be like a silent disease. Like a person wouldn't know they have kidney disease because they don't feel any way, or they don't have any symptoms. Symptoms usually don't come up until a person's kidney function usually drops maybe like 15%. And so there's 5 stages of chronic kidney disease. So in order to be diagnosed with chronic kidney disease, there's several different criteria. So as I was talking about the EGFR, the estimated glomerular filtration rate, that's a calculation that's done. So if like you have blood work that's done by your provider, usually it will have your creatinine on there, and it'll have EGFR on there. So the definition of chronic kidney disease is having an estimated glomerular filtration rate of less than 60 with or without evidence of kidney damage, or there's evidence of kidney damage with or without a decreased GFR for greater than 3 months. And it could be, you could have an EGFR of say 100%, but you have protein in the urine. So protein is an indication that there's damage going on to the kidney. So that's one of the things. Or say you have blood in the urine, and that could be caused by like a urological condition, or they do a renal biopsy where they put in a little needle and get a piece of the tissue sample from the kidney, and it shows that you have a specific type of kidney disease. So that's another way. Or we do a CT scan, and incidentally they find cyst on the kidney. So we call it polycystic kidney disease. So you could have polycystic kidney disease, but you could have cyst all over your kidneys, but your kidney functions normal. So those are different ways of diagnosing or defining someone with kidney disease. So with CKD, there's 5 stages. And so the first stage is having your kidney filtering greater than 90%. That's considered like normal or increased glomerular filtration rate. Stage 2 is we consider mild. That's when your kidney functions between 60 and 89%. Stage 3 is moderate loss of kidney function. So there's stage 3A and stage 3B. So stage 3A is like kidney function between 59 to 45%. Stage 3B is kidney function of 44 to 30%. And then there's stage 4, where your kidney function, that's severe loss of kidney function, where your kidney functions down to 29 to 15%. Then stage 5 is end stage kidney disease, or CKD stage 5, or basically kidney failure. So that's when kidney function drops below 15%, and usually dialysis or some type of renal replacement therapy is required at that time. How we diagnose and screen for kidney disease usually is if you go to a provider. Sometimes if they do urine tests and they check for protein, if you have a small amount of protein in your urine, that's an indication, that's a marker for kidney disease. So that's important to always check to see. There's CKD risk factors to look out for. So again, the 2 leading causes of kidney disease in the United States is, number 1 is diabetes, type 2 diabetes. Second is hypertension. And then if you have both, then that's a double whammy. Other risk factors would be like having, say you have diabetes, that's a risk factor. Or having hypertension, that's a risk factor. Or if you're a current smoker, that's a risk factor. Being obese is a risk factor. Being age greater than 60 is a risk factor. And then being a part of like an indigenous racial origin, like say being an American Indian, or also maybe being Hispanic, being African American. Those are populations, races that have high incidences of chronic kidney disease. So, and then also having a family history of kidney disease is also a risk factor. So say like my father, he had kidney disease. So I'm at risk for having kidney disease. So that's a risk factor. And having cardiovascular disease, say a person was diagnosed with a heart condition, that could also be a risk factor. So let's see, what else? So age, family history, race, ethnicity, smoking, obesity, cardiovascular diseases are risk factors. So let's see. So if you have any of those risk factors, you want to make sure that you want to get screened for chronic kidney disease. So, and one of the things that your provider can do is check a urine for urine microalbumin creatinine ratio. That's what we call it. We check for protein in the urine. And always, the way primary care providers diagnoses it is if they see the creatinine and see the EGFR, and based on that level. And then we usually don't diagnose again just based on one reading. We have to see if we have to repeat it, and at least twice over like 3 months to exclude that there's no there's another condition called acute kidney injury, and that's uh, where your kidneys can recover, get better. Like say you went out hiking or running and you weren't hydrated, and that can cause kidney injury. And so usually a person can recover from acute kidney injury if you don't have chronic kidney disease. So if you have healthy kidneys and you had an episode of acute kidney injury, that's when your kidneys will recover. But when someone has chronic kidney disease, you can also have acute kidney injury on top of your chronic kidney disease. So that's kind of different. So there's acute and there's chronic. Acute, your kidney function gets better. Chronic, it usually does not get better. So um, let's see. So chronic kidney disease, it affects, like I said, it affects different systems in the body. It can affect our bones. It can affect our heart. It can affect blood pressure. Blood pressure can cause chronic kidney disease. Chronic kidney disease can cause blood pressure, so it goes both ways. Let's see. It can also, other complications that kidney disease can cause is, okay, high blood pressure, anemia, that's low blood count, because our kidneys make a hormone called erythropoietin, and that hormone, um, the way I explain it is it sends a message to the bone marrow to make red blood cells. So when the kidneys aren't working like they should, it doesn't make enough hormone, so a patient becomes anemic. So that's a common complication. Kidney disease also weakens the bone, so it has to do with the electrolytes. It has to do with the calcium and the phosphorus and the parathyroid hormone. So we call it renal bone disease. So anytime I have a new patient, I'm checking calcium, phosphorus, parathyroid hormone, and vitamin D. So um, I usually don't see high phosphorus levels until, say, maybe a patient's at stage 4, stage 5. But in the meantime, I start seeing, we call it secondary hyperparathyroidism. That's a condition where it affects the bone. So we have, the way I kind of think of it is we have 4 glands in our neck that sit on top of the thyroid. So it's different from the thyroid. So it's not, so on top of the thyroid, there's four little glands, and it gets triggered when it senses an imbalance between calcium and phosphorus. So uh, the way I kind of think about it is when our kidneys help filter out the phosphorus. And so phosphorus is in many of the foods that we eat, even processed foods. It's huge. So when a person has chronic kidney disease, and remember, our kidneys are a coffee filter. So when you have kidney disease and the filter's not working, that phosphorus starts to build up in the blood. And once that phosphorus builds up, um, the parathyroid hormone gets triggered, and it sends a message from the hormone here to the bones to break down bone and release calcium into the blood. So it compensates. So it's kind of like a seesaw. So with kidney disease, it's phosphorus goes up and calcium stays down. And so when that gets triggered, when the bones break down, it tries to balance it back out. So in the meantime, um, normal bone metabolism, the way I think of it is our bones are constantly breaking down, but it rebuilds. So that's how our bones stay strong. So when a person has chronic kidney disease and their parathyroid hormone level is elevated, uh, we try to slow it down. We don't want to stop it, but we want to put the brakes on it. So we give a vitamin D. And so that vitamin D, what it does is it just puts the brakes on the releasing too much hormone. So it balances out. So we look at that. So that's renal bone disease. And sometimes when we have patients that have high phosphorus levels, we have to give a medication called phosphate binders. So uh, the way it works is when a person's ready to have a meal, we have the patient take that medication and they start eating. it binds the phosphorus in the gut. That medication binds to the phosphorus. And normally, with a healthy kidney, you can pee out the phosphorus. But in this case, when you have chronic kidney disease and it's not filtering out, the washing machine's not working, the way we get rid of it is the phosphate binder. Patient has a bowel movement, and that's how we get phosphorus taken out of the body. So that's renal bone disease. So we look at that. A patient, say with chronic kidney disease stage 4, we recommend a potassium diet limit of like 2,000 milligrams in a day. So let me see, I like to tell patients, when you do food label reading, you want to look at, like, say, the potassium. And so a daily potassium intake for a kidney patient is 2,000 milligrams. So a high potassium level is dangerous for a kidney patient. So we have to, when I see a patient, I'm looking at the potassium level. There's certain medications that can cause high or low potassium levels, certain diuretics. So we look at the potassium. Albumin, we also look at albumin. That's a protein in the blood that we look at. And as a kidney patient, that can give us an idea of, say, the nutritional status of a patient, to see if sometimes when a person is going into kidney failure, they start losing their appetite. And sometimes the albumin can be low when a person has large amounts of protein in the urine. So they're basically peeing out the protein through the urine, and the protein in the blood can be low. So we also take a look at that. Another thing we look at, and it's is the acidity in the blood. So we call it acidosis. Our kidneys help manage the acid-base balance in the body. So our body naturally produces acid, and it comes from our daily diet and the proteins that we eat. So normally kidneys keep the body in balance. So it helps by excreting acids. But when chronic kidney disease happens, the kidneys loses its ability to balance it out, and acid accumulates in the body. So we have to sometimes have patients take, I call it a baking soda pill. That's basically what it is. It's a sodium bicarbonate tablet that we give patients to help balance out the acid in the blood. And if we don't treat the acidosis, there's a risk for the kidney disease to progress. And so treating the acidosis helps slow kidney disease progression. So that's one of the other complications that can happen. So let's see. So potassium, phosphorus, calcium, albumin, bicarb. So that's bicarb. That's the acid-base balance. So those are complications those are ways that we treat these complications. To slow the progression of kidney disease, blood pressure control is very, very important. So we tell patients less than a teaspoon of salt per day is the limit, like less than 2,000 milligrams per day is the limit for anyone with kidney disease or who have high blood pressure, because high blood, salt can cause your blood pressure to go up. It can cause you to retain water. So I always tell patients that less than a teaspoon. I tell patients do not use salt substitutes like Morton light salt, new salt, because it's basically potassium chloride. And so I tell patients, if you want to use a little bit of salt, like say on your eggs or whatever, use regular salt, like any kind of salt, like Himalayan salt. Salt is basically sodium chloride. So, but don't use the salt substitute. So, and I also tell patients you can use Mrs. Dash, any type of seasonings like garlic and seasonings like that to season your food. Mrs. Dash, that's good. So blood pressure control, our goal is less than 130/80. So That's really important. We don't want the top number of the blood pressure to drop below 100 because that can affect the perfusion of the kidneys. So blood pressure control is like one of the main things. Diabetes control is also very huge. We want good diabetes control because it can also worsen kidney disease. We want the hemoglobin A1C goal to be 7% or less. So that's very, very important. And when patients have both high blood pressure and diabetes, it's very, very important. So usually if a person's diabetic, I'll have them see maybe endocrinologist, somebody that specializes in diabetes. We have good medications now that help, that have shown, have proven, I get that have been studied to slow the progression of kidney disease down. And another thing that can cause kidney disease and actually worsen kidney function is, we call it non-steroidal anti-inflammatory drugs. That's basically ibuprofen, Motrin, naproxen sodium, indomethacin, meloxicam. You want to be careful with those types of over-the-counter medications. I've had patients come in who develop kidney disease from taking too many NSAIDs. So you want to be careful with that. So we tell patients, we give them a list of NSAIDs not to take. Tylenol is okay. So, and let me see. Drinking plenty of water is really important. We say at least 2 liters of water a day. So that's very, very important. Since our body's made up of water and our kidneys need to be flushed out, filter. So 2 liters of water a day. Let's see. Let's see, what other, let's see, lipids. So if you have, say, some patients with diabetes have high cholesterol. So that's very important. We want to make sure that the LDL, we call it the lousy cholesterol, that's under 100, because that's also very important. Let's see, taking a baby aspirin, that's okay. It's an NSAID, but baby aspirin's okay. I always tell patients too that you want to make sure that you remind your, sometimes, if they go into the ER urgent care, that you're a kidney patient, that you want to make sure that your medications are appropriately dosed, that you're not getting a medication that's nephrotoxic. So that's another thing to look out for. Most meds, patient with chronic kidney disease, most medications need to be renally dosed based on the kidney function, so you don't get overdosed. And it has to be adjusted based on the EGFR, the estimated glomerular filtration rate. Let's see. Is there, is there any other questions? Oh, I meant to say nutrition. So we recommend a Mediterranean type of a diet. When a person has chronic kidney disease, we want the patient to limit the animal protein. And usually there's a calculation that we do if a person's spilling too much protein in the urine. It's recommended that it's 0.8 grams of protein per kilogram of weight. So it's basically individualized. So the patient comes in and they have a lot of protein in the urine. Based on their weight, I'll calculate and say, hey, your limit is, say, 60 grams a day. And I'll give them a handout on high protein foods. So we kind of go over like, okay, if you have 2 whole eggs, that's 1 egg is 6 grams. And if you have 2, that's already 12 grams. So, I tell them to mentally do that in the head to just calculate. So when you have chronic kidney disease, a high protein diet is very good for a patient because it stresses the kidneys. The more protein you eat, the more you're spilling. So that's another thing to think about. So we recommend like a balanced, healthy diet with fruits, vegetables, fiber, plant-based protein. So I tell a patient, if you want to say you're working out and you want to have a protein smoothie, go for the plant-based. There's the food stores like, that have plant-based proteins where you can make a smoothie. Choose unsaturated fats, nuts. Those are things that that a person can do. Let's see. Okay. Oh, another thing too, I was just thinking about, like, say if you're a kidney patient and your doctor's recommending, say, a CT scan or MRI with contrast, they can call your kidney provider and talk to them about it. Sometimes it's okay to have it if it's really necessary, as long as they flush out your kidneys with normal saline before and after, and your kidney functions monitored. Then usually I will okay it. Let's see. Exercise. That's very important too. Exercise, weight. Okay, so that's really important. So I tell patients, try to exercise even if you just walk for 30 minutes. That's really important. Higher BMI patients, we recommend weight loss because it's shown, of course, to help the blood pressure, the diabetes, the glucose control, but it also can decrease the protein in the urine. So it also can help kidney function. So sometimes when I have a patient that has a high BMI, we recommend bariatric surgery. And that's one thing that we recommend. And not only that, we want the patient to have a healthy BMI too, so that they can qualify for transplant in the future. That's a transplant recommendation. So that's what we recommend. And let's see. I'm trying to think of what other questions are regarding chronic kidney disease. There's so many. I mean, chronic kidney disease can also be caused by other genetic causes or other types of diseases that are complicated, or that may require a kidney biopsy. So there's genetic diseases like Alport's, polycystic kidney disease. If, say, you know that you have cysts on your kidneys, and there's certain types of genetic kidney disease that can be passed down to kids, like to your offspring. So I've had patients that come in and we do a genetic test to figure out, is this polycystic kidney disease? And so PKD1, like, is it a genetic one where it could progress? And then there's testing that we can do to see how fast the kidney disease will progress. So, and then that way, if they have children, if the children want to be tested, they can, at least they'll know if they have that passed down. So there's that. Let's see. And if I have a kidney patient that's a smoker, I try to encourage smoking cessation because it can worsen the protein in the urine. It can cause kidney disease to get worse. So let me see if and like I said, there's medications on the market now that help with slowing the progression of kidney disease down. So that's something that you can talk to your kidney provider about if you meet the criteria, or so that's, but let's see. What other?
I do have a couple of questions.
Okay.
As well. You had mentioned in your presentation that age can affect your kidney function. So when should you go into your doctor and ask, would it be okay to go into your primary care physician and ask, can you check my kidney function? Or is that something at a certain age you should be concerned about?
Okay,
You,
so,
you know,
oh yeah, so if you go see, say, your primary care provider and they do your test, it'll have the EGFR on there. So like, say, for instance, say if I have a patient that's 30 years old, I know that their kidney function should be 100% at least if they're healthy. But say they're 30 years old and their kidney function is down to 30 or 40%, then that's definitely a red flag. That's not correct. That's not right, So sometimes that will determine if it's chronic, or rechecking it will determine whether it's chronic or it's something acute, like I was saying, like the acute kidney injury. So yeah, so like anytime you go and get blood work done, it's usually the creatinine is usually in a basic metabolic panel, a comprehensive metabolic panel, or a renal function panel. So that's usually, creatinine's usually in there, and the EGFR, the laboratories are required to report that. So
okay, perfect. Because we get that question a lot, is when should I ask? When do I have to wait till my kidneys hurt? Do I have, when should I? So it's good to know that that's usually in the metabolic workup. Okay.
yeah, and remember, you could have normal kidney function, but the way to tell if you have kidney disease is to get your urine test done. And that will show whether you have protein or if you have blood. And that, the any urological conditions have to be excluded, to see if it's coming from the kidneys. So if you have so if you know that your kidney function is normal, I would say just get a urine test done to see if less than 30 milligrams of protein in the urine is considered normal. Less than 30. Anything above 30 is either microalbuminuria, and some patients could be spilling in the thousands. So anything greater than 3,000 is considered nephrotic syndrome. So that's huge. So the more protein that you spill, the worse it correlates with how fast your kidney disease will progress. So if you're diabetic and you have high blood pressure, and you're spilling 10,000 grams of protein, that's almost like, how could you say, inevitable that the kidneys are going to fail, so that's why it's really important. So catching it early, yeah.
Okay. I really appreciate it. I have been doing this. I love my job. And I've been doing this for 3 years. And I love it because I get to talk to you practitioners. It's like one-on-one with these specialists like you. And I just love it. I had never heard of cyst on the kidneys. And someone very close to me had some testing, and he has cysts. He has 2 cysts on each kidney. And of course you think of cysts and you freak out, right? So, but I really appreciated that you did point that out, that you can have cysts, and your kidney function can be just it could be normal. So do I understand what you were saying correctly?
Yeah, so there's different types of cysts. So as well, there's different, so usually when a patient, say we send a patient, say I have a new patient, and we do x-ray, or sometimes a CT scan, whatever the case. But if they have a cyst, you could have a tiny cyst on one kidney or on the other kidney. If it's a simple cyst, normally it's benign. We don't do anything about that. You can have a cyst on the liver, you can have cyst anywhere, it's a fluid filled sac. But if it says a complex cyst on your kidney, then usually we, nephrology will refer that patient to urology. So I think of urology as they deal with the plumbing. They do and usually they'll probably do like a biopsy or something to see, but there's different types. But if if say, like I've had a patient, young patient, she had happened to, it was kind of incidental how they found it. I think she had a x-ray done of her abdomen or something, and she found out that there was multiple cysts on her kidney. When it shows that sometimes the radiology report will say multiple cysts, like then you likely know it's probably polycystic kidney disease. And at that point, you can do a genetic test. So we have genetic tests that are available here, where, so, and on the other hand too, if there's electrolyte abnormalities, like say, a patient's chronically having low potassium, that's usually common, or spilling glucose in the urine, and they're not diabetic, or they're not on a medication that causes glucosuria. We'll do genetic testing because there's genetic diseases, kidney diseases, that can cause some of those abnormalities. So yeah.
Very interesting. Thank you so much. I don't have any questions from any of the viewers that are watching tonight.
Okay.
But I just found it is very, very interesting. You know, I really appreciated how you went over how hypertension and smoking, obesity, age, race, all these can be a factor. So it's something that we all have to be aware of. And really check how, and you discussed how important it is. So if you are diabetic, how important is it to be aware of your diabetes and to be like to take care of yourself as a diabetic?
Okay, so if I have a diabetic patient, or if you're, say, you don't even know if you have kidney disease and you're diabetic, you want to always ask your provider, because usually providers will check the urine, and if they check the urine and say that, we call it microalbuminuria, if they check the protein, if they check for protein in the urine and it's greater than 30, that's microalbuminuria. That means that you have kidney disease, you have damage going on in the kidney. So if you're diabetic and you don't know that you have kidney disease, that's the first thing that they can do, is screen your urine to check for protein. That's like the number one thing. And if you're diabetic, my best advice is to get that A1C under really good control, tight control, like 7% or less. And there's really good medications on the market right now that can protect the kidney, the heart, and lower glucose.
Right. Perfect. I've been listening to, for 3 years, we've had this kidney talk. I didn't know that cardiovascular disease was a risk factor. I had never caught that in any of the information or the talks. So that, to me, when you said, I actually wrote that down in my notes, cardiovascular, because that was a new thought. I didn't know that heart disease could be a risk factor, which makes sense, but it could be a risk factor for your kidney, for chronic kidney disease. So I really appreciate that.
Or say, just if you have, if there's a patient out there that just, say they're not diabetic, but has high blood pressure, that's also a risk factor in itself. It can cause kidney disease. So, and I see it all the time here in the clinic.
Right. Well, Stephanie, that's all that there is tonight, but I just wanted to thank you. It was such a pleasure meeting you and hearing your presentation. Like I said, I took a lot of notes, so I learned a lot, and I appreciate your coming on and spending your evening with us. Thank you so very much.
Thank you so much for inviting me.
Yes.
Okay.
And to everyone, thank you for joining, and we'll see you in January. Thank you. Good night. Good night, Stephanie.
Yeah, thank you. Good night, everyone. Bye.
Bye-bye.